Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we're going to talk about something that everybody knows something about, and that is the drip, the Syntocinon Drip.
Syntocinon Drip in labour.
Yes, and why some people say no and what the evidence actually says. So what I want to do for this one is bring to you the arguments that people might have.
Okay.
And then we're going to talk about the benefits so people can see what the objections might be towards the Syntocinon Drip.
Yeah.
And then what they can then learn about to help them make some decisions about their progress in pregnancy and labour and birth.
Good one.
But, now we've said Syntocinon Drip and just expect everybody to know it. So let's start there. What is it?
Well, Syntocinon is a drug. It's called various things around the world, but it's a synthetic form of the natural labouring hormone, and it helps in labour if there's a good reason why we would want the labour to either start up or to go faster and stronger. And good reason is an important part of that discussion. It's a drug that has to be used for valid reasons, and there are some risks in using it, so we need to be careful of how we use it.
And people will know the two terms, won't they? They'll know induction and maybe they'll know augmentation. Yeah.
So let's talk about those two things because they're very often blurred in discussions about this, and it's important that they're not. Using Syntocinon to induce labour, the most common scenario that I can think of would be that the waters have broken. So come to term, waters have broken, but no labour comes. And this happens a bit. And therefore there's a infection rate where bacteria from the vagina can get up into the water around the baby. And newborns do poorly when they're born infected. So after a period of time, if the labour has not come, sometimes the appropriate advice is to use some Synto to get that labour up and going. And that's using Synto to induce, so to bring about a labour where there is not one, okay? Because the water's breaking, that doesn't count.
Can I just talk about the water's breaking? So, I mean, if somebody's picked up this episode because they've been told that they should think about having an induction and they're going to have that induction started by the drip, and they're hearing for the first time that waters breaking don't necessarily equate to the start of labour.
Yeah.
That is at odds to every single movie.
Every movie you've ever seen.
Yeah. That's
right. That's not how it's done. So the minute the waters break, the big strong contractions come. That's not how it really works. There's often several hours. There's sometimes days, and there can be weeks.
Weeks, yeah.
Yeah. So those events are not necessarily one immediately following the other.
Yeah.
So infection is in that scenario is the potential problem. And if we look, for example, at somebody whose waters have been broken for 24 hours and there's still no labour, we have to weigh up the risks of doing nothing and letting that situation continue versus the risks of intervening by starting up a Syntocinon Drip. And too often the discussion of risk concentrates on the risk of the intervention and ignores the risks if we don't do the intervention.
That is so true. So we've talked about induction with the drip. What about augmentation with the drip?
Augmentation's different. So that's when a labour is up and going but doesn't seem to be progressing well. And this is, there's all sorts of arguments about how fast a labour should go and what's optimal and what's best and so forth. But everybody agrees that we should have some progress at some point. So if a labour has really stalled, let's say we get to about 4 centimetres, examine the woman again later on and find that there's been no progress in the intervening time. And in fact, when we look at the contractions that have happened in the 4 hours between those examinations, there's really been no useful progress at all, but also no really strong contractions either.
They've petered off a bit.
Yeah, they've petered right off. And we knew from observations that historically that those people, the outcomes were poor for those women and those babies. And labours that went on for a particularly long period of time and were left to progress entirely without intervention, the outcome for those women and those babies was poor. And so when we look at the really disturbing data for obstetric outcomes prior to the middle of the 20th century, the group that needed help and weren't getting it were women in particularly prolonged labours.
You say that thing about, you can't let 2 suns set or something.
Oh, yeah, it's a bit of a flippant
old thing.
Yeah, a bit of a flippant old thing, but it's basically that that labours there's compelling data that a progressive labour is a good one. So augmentation is using the syntocinon to make a slow labour hurry up.
I forgot to mention at the start that some countries call it different things, don't they? There's Pitocin.
Yeah, it's the same thing. It's just a different name. Yeah.
Because it is one of the most widely obstetric drugs used in the world, isn't it?
Yeah, and the careful and sensible and safe use of that drug is one of the many reasons why the data for pregnant women improved so dramatically in around about the middle of last century, and why it's never been safer to have a baby.
All right, so I've looked at the arguments. I've done my research. AKA Google research.
Well done.
Good. And I got these from Reddit, okay? So
Journal, the International Journal of Excellence.
Yeah. Number one argument that I found was that the contractions are more painful and intense. So people say things like they got really intense really quickly, I didn't get a break between contractions, and people who had it and also had a birth without it said that the contractions were a lot worse than natural contractions.
Yes. So let's divide those up into a few different things to examine. Firstly, the contractions that we're talking about that help us in our first labour to get from 0 to 10 and let the baby out, they hurt. And useful contractions are painful, very painful. And so to say, if we're talking about syntocinon made my contractions more painful, of course it did. That is what it's supposed to do. And mostly when someone says I had one labour with it and one labour without it, she's comparing her first labour with her second, which we've discussed elsewhere on the podcast is not comparing apples with apples. So the first labour is long and difficult, and second and subsequent labours, on average, are better. So it's particularly fraught to compare one with the other. Yeah. So if we make a better and safer comparison, which is safer in terms of the quality of our data, between a big group of women who have syntocinon in a certain clinical scenario and a big group of women who have syntocinon who don't have syntocinon in the same scenario, say stalled labour at 4 centimetres, then we know the Synto group leads to better outcomes. What we don't want to do, but they will also have more painful contractions. Of course they will. We're restoring painful contraction, which of course is going to lead to pain. What we want it to lead to is contractions that are effective and put that labour back on track. the comment that somebody made there about I didn't get enough of a rest between my contractions, that is a potential red flag that the Synto may have been used incorrectly. So when we are in labour, good, strong labour, the baby's getting oxygen when we're not contracting and not when we are. So there needs to be a long gap between contractions to refill the store of oxygen that's sitting in that no man's land between the placenta and the baby, so that the baby, there's some for the baby to use right throughout the cycle.
And what would happen if somebody said that, in between contractions, they put their hand up and they I'm not getting a break here? Well, firstly, you would hope that somebody would realise that the contractions are coming too hard and fast.
Yes.
But secondly, can they say, can I turn the drip down, or can the drip be turned down?
Yeah. So this is not something that we need to rely on guesswork here. When a Syntocinon infusion is running in Australia, there's two things that should be happening. One is that person should have a midwife with them at all times. This is a potentially dangerous drug. It can be overdone, overused, and lead to very poor outcomes. But that doesn't mean that if it's used properly and safely, it isn't excellent. So what we want someone with that woman at all times. And one of the things that attendant attendant to the birth should be looking for is whether the Syntocinon is being used at a drip rate, so the dose, to bring about what we're looking for, which is a certain number of painful contractions every 10 minutes with a nice gap in between. To restore the pool of oxygen in a way that can be used by the baby.
Great. It sort of leads to the next argument, because if they're more painful, people say you start the drip and you have created the cascade of interventions.
Yes.
And for first-time listeners, cascade of interventions, people mean sort of like the drip, more pain, epidural, leads to instrumental birth, then caesarean birth, then, so people think that you open the floodgates for all that intervention happening.
Yeah. It's an interesting idea. There is a lot of anecdotal evidence that the cascade of interventions exists as a phenomenon. There's less proven evidence, but let's assume for a moment that it does exist, and it probably exists in some form or another. It's very difficult in an individual case to know whether, let's say, for example, we look at Syntocinon used in that first example where we were giving the Synto because the labour had not come after a certain amount of time, and the big ticket intervention, the big ticket problem that we were trying to avoid was the labour taking so many hours or days longer. The period of time that the waters were broken was going to take so many hours longer, and unless we got on with it. So it's very, very difficult to know whether the Syntocinon-induced labour caused more pain than that woman was going to have had she just laboured spontaneously, because that is also painful.
But there is an increase of women needing an epidural if they do have the Synt.
That is probably true, and there's certainly some studies that have found that. And one of the problems might be that it comes on pretty hard and fast, rather than the natural one that would potentially creep up on us. And if they're very severe quite quickly, then there might be in the mind of the labouring woman more of a stuff that this is really bad, and I was comfortable half an hour ago, so now I want an epi.
Yeah.
Whereas the woman with the natural labour that creeps up in intensity might be more able to be used to that or withstand that.
So someone that gets the drip might end up with an epidural.
Sure,
higher chance of getting epidural, but an epidural doesn't lead to a higher chance of caesarean.
No, that is a commonly believed thing that there is very little evidence to support that. And in fact, there are studies that don't show that at all. You've got to remember that the use of Synto in the stalled labour might be the only thing that gets you to the starting line of a vaginal birth, which is being fully dilated. Does that make sense? So I think that if you are in a stalled labour at 4 centimetres and you don't
what do you got on your side?
Have some Synto, that's going to have a section rate if we do nothing that approaches 100%, because the baby can't come out through 4 centimetres cervix. If you have the Synt, warts and all, and get to fully, you are at least at the starting line of a vaginal birth.
And, there's no judgment in there. You might get to 4 centimetres after, I don't know, an 8-hour labour and think, 4 centimetres, they've suggested that I have syntocinon or caesarean.
Yeah.
And you might go, I've done it already, labour, I'm going to go for a caesarean.
Oh, sometimes people do that.
That's fine.
Yeah, that's also fine. But let's say the goal is vaginal birth. Let's for the sake of this discussion. Then sometimes I'll say to people, you've been labouring all night and we're still only here. I'm now proposing that to get this labour back on track and give us a tilt at getting to fully and a vaginal birth, the best course of action here is to use some Synto and try and restore adequate progress. You're already exhausted. You sure you don't want an epi up front?
Yeah.
And we'll often do that.
Yeah.
So put in the epi first. And then ramp the Synt up and see how it goes.
Yeah.
Yeah.
And then that can all sort of wear off towards the end anyway. And if your goal is to have a vaginal birth where you feel like you're not medicated, then
an unassisted vaginal birth, yeah, that's right. Then you can certainly do that.
All right, I want to move to argument 3, which is that it increases risk, and now you've touched on that. So what sort of risk is the main problem with Syntocinon drips?
Well, we need to look at the risks of using it and the risks of not using it. But let's say we start with the risks of using it. Those are, allergic reactions and things like that are extremely uncommon. We're talking about using it in a way that overstimulates the uterus and can lead to very big contractions coming on one on top of the other. And these are typically dosing errors. So we need to be really careful. You've got to be careful on everyone you use Synt on, particularly people who've had a baby before. It doesn't take much. So if someone's had a previous vaginal birth, ruptures their membranes at term and then the labour doesn't come, and the sun comes up the next morning, we're still not in labour and you want to use a bit of Synt, you do not need much. So a whiff will get that woman into labour. And it's not like using it to, in a stalled labour in a primip where really we push people pretty hard.
But not too hard, because I've heard you say also that that someone was pushed a bit hard, or the Synt has really flogged them.
Yeah,
and
whooping people along. Whereas the woman who's had a baby before, just to finish that thought, she does not need much, and a little bit trickled in will get her actually up and labouring pretty much by herself. We don't often do this, but you could almost turn it off again. Yeah. And some of those women would be up and away. The woman having a first baby is not like that. If the labour is progressing slowly, we often need to start the Synto, and we start at a really low dose because we don't know how much we're going to need to give
how sensitive they're going to
get the result we're looking for. So we start off at a really low dose, and then very carefully watching how the woman and the baby are responding to it, increase it until we get to a frequency and duration of contractions that works to actually put the labour back on track.
All right. So is that the only risk? The hyperstimulation of the uterus?
Yeah, so hyperstimulation is where we get just a whole lot of contractions coming one after the other, and you think, oh, well, as long as we haven't had any previous Caesars or something, the uterus is pretty strong and made of muscle, it should be fine. But it's not really about that. It's about the baby getting enough oxygen, and you need a gap between contractions to ensure that happens.
And a tired uterus, I've also heard you talk about postpartum hemorrhage risk.
True. The tired uterus is part of using Synto, but it's also one of the problems with significantly prolonged labours. So we may actually be using Synto to avoid the sort of problems that happen if you labour for 3 days.
Okay. All right. Argument 4. I heard this a lot on Reddit. And I'm just surmising that being attached to a drip or the continuous monitoring, all of a sudden their birth has gone from feeling natural to feeling medicalised.
Yes, and needless to say, that's true. It is definitely true. We're having our baby in the hospital. If things are going significantly away from a speed and efficiency that we know is associated with good outcomes, you're likely to be recommended intervention. Now, those interventions are not bad ideas just because they're interventions. It was interventions that fixed the data, that nature's data, which was unacceptable to the people of 100 years ago. For 1% of women who got pregnant to die from that pregnancy was unacceptable to those people. Think of the cumulative misery.
Yeah.
And it was interventions that fixed that.
So people talk about less mobile, but you can still move around with the drip.
Yep. So you can. We don't tend to have people walking the corridors with a drip because of the need for electronic fetal monitoring. We want to make sure that we're not overstressing the baby with the Synto. But certainly around the room, that's fine.
And is it always continuous monitoring that you need if you're on a drip, or can they put it on and off a little bit?
No, we have continuous monitoring for people on Synto because often the first sign that that too much is being given is a change in the fetal heart rate, which is the baby saying, I'm not getting enough oxygen here.
Yeah.
Because you aren't giving me enough of a rest between contractions.
Fair enough.
Yeah. So the woman won't necessarily notice that, but the baby will. And the woman might think, gee, this stuff's working, I'm cracking along here, but that's not what the baby needs.
Yeah.
Yeah. Whereas in a hyperstimulation that occurring naturally is quite uncommon for a natural labour, so that so a listen after each contraction is fine.
Yeah.
Yeah.
So what about they can't go into a bath or anything like that if they're on a drip?
No, but that not in our setup. But I think that we're often using this in a scenario where things have not gone according to an entirely natural and an entirely non-interventional model. Reddit would have you believe that these are interventions that are somehow forced on people. I don't believe that's commonly true. I think that the standard these days, certainly in Australia, would be to go in and sit down with that woman and her support people and say, here's where we are. Here's our progress so far, and here are my concerns. And then, like any medical intervention, for any reason, whether you've got a pimple on your nose or are having a baby, what are the risks and benefits of the intervention you're talking about? What are the risks and benefits of doing nothing? What else have you got? And can I have some time to think about it?
Yeah. I did forget to ask, if you've had the drip to start, so in an induction, and you get into good labour, can all of that be switched off?
When you're having your first baby, it really needs to keep running, and in fact, the dose often needs to be increased.
Oh wow! Okay.
Yeah. So if you switch it off, it tends to go back to where it was, which was stalled. Yeah. Second and subsequent births, it's not really like that. You can use a sniff and get going, and you probably could switch those off.
Good. All right. This is my last argument. I'm sure there's others. Email us or DM us if you think there's another argument that you want to have discussed. And this is harder because it's those that really don't trust that advice, that they really needed it in the first place. You know, they sort
Yes.
of are questioning whether their labour was truly stalled and whether they were given enough time to wait.
Yes, well, that is a different question altogether because that comes down to, see, I've drawn this example for the ease of our discussion today about someone who's not labouring at all and has a clear infection risk and there's a clear problem with doing nothing. Where it gets more interesting is the scenario in which, for example, the induction wasn't done for a good medical reason. Yeah, so there really was no problem. Everyone just thought it would be more convenient to have the baby that day, or somebody thought it was, or whatever. Well, that is different, and that, I think, is where the actual discussion should be parked. It's, do you need to be induced in the first place? If you really, really want to avoid intervention, come into spontaneous labour at term. Yeah?
Easier said than done.
100%. But I'm just saying that that's really where the discussion should lie. I don't think that there's any particular problem with the careful, sensible, expert use of Syntocinon. I think there's a problem with inductions. Yeah. So if we look at that, inductions for first babies that have a high risk of ending in caesarean section. Yep, there's an issue there. And I think our birthing services need to be flexible enough to allow more of those women to cautiously wait.
It's hard, you know, because Australia is geographically kind of challenged.
Yep.
And some people will have an induction because they've had to fly in to a regional city or a city. Even some of our people that live 3 hours away from Ballarat, you know.
Yeah. Well, they're the most likely of my patients to be induced. And for those people, sometimes it comes down to the risks and benefits of induction versus the risks and benefits of labouring spontaneously and being 3 hours from their birthing hospital. So different discussion. Yeah. But if we want to shift the argument to somewhere where it can actually lead to better outcomes for women, it's probably shifting it over to, can we get this woman to a point where she can be safely and expertly managed without inducing a labour, rather than just saying, well, the only thing we can do for you, madam, is to get you going. Yeah.
It's so difficult because, you know, you have the, I've forgotten what it's called, the massive big one where they managed to convince people to have an induction at 38 weeks.
Oh, the ARRIVE trial.
The ARRIVE trial. I should have known. ARRIVE,
39 weeks,
Yeah. So, you know, so they're saying actually there's less caesarean rate if you get induced at 38 weeks, and that became a bit of a thing.
I think it raised more questions than it answered, to be honest. But no, I think that labouring spontaneously at term is still a good thing.
All right. Now, they're the arguments, and I'm sure there are more. So as I said, just DM us if you want something discussed. But let's talk about let's just wrap it up, Pat, with what the benefits are. Like, you know, we've talked about why people wouldn't have it, and in between you've put little bits of why you think Syntocinon's a good idea. Yeah. So let's talk about some benefits.
Well, it works.
Oh, it works, yeah.
So that is the bottom line. It works. The receptors within the uterus respond very, very well, and it will get you back on track if there's something wrong with your labour. And if there's nothing wrong with your labour, why are we using it in the first place? This will get you back on track. In a lot of cases, much, much more effectively than all they used to have, which was the tincture of time. You just waited and hoped it went better. It is very, very effective at doing that job. Used sensibly, expertly, carefully, it's a very, very good intervention.
And you mentioned that because it does help people deliver within 24 hours, it helps to avoid caesarean in certain cases.
Well, that is why it's used. And so it's sort of sometimes a little baffling to obstetric practitioners that we just hear all the problems with it as if we're using it for no reason. But if somebody's labour is stuck at 4 centimetres, that person's going to have a Caesar in just about every case. Syntocinon is to get you to fully so you don't need one. And that is that's a common misunderstanding. If I have Syntocinon, I have a higher section rate. I don't think that's at all true. In fact, the reason why the labour is being pushed along is to get you to the to 10 centimetres, where a vaginal birth is only then becomes a possibility.
All right. So, we've got the medical world saying it works, it's been studied lots, it can prevent escalation, it can help people avoid cesareans if that's what they're up to. Why is the medical world saying one thing and pages and pages and pages on Reddit are saying another thing about induction? Why do people fear it?
Well, I think it gets back to that argument about what we are talking about when we talk about risk. So the medical world tends to look at population level risks. What happens to 100,000 women in this situation if we do nothing compared to what happens to those women if we apply treatment ABC, which might be Syntocinon augmentation of labour. And the problem with what we read on the internet is it tends to be somebody's individual experience. They gave me that Synto. It didn't work. I had an epi and then a Caesar. Must have been the Synto's fault.
Yeah.
But the Synto was only given because the labour had stalled. That was actually the problem. And so that person leaves thinking it is useless. Fair enough. Then that person can get on the internet and say to everyone else, it's useless, don't do it. But in fact, if we look at enough people, the exact opposite is true. It's useful. And in that scenario, the evidence-based thing to do is to do it. It won't always work. But if you want to know where the data leads, it leads to the sensible use of that intervention.
So if people are getting conflicting messages online and then they sort of say, absolutely no, it's not in my birth plan, I've underlined it like 100 times, no induction, no Syntocinon. And then it comes to the situation where they are recommended to have Syntocinon. What are some good questions they can ask their provider? You have to.
So it's a great question. So I'm gonna.
I know you've just sat up straighter in your chair. You got all excited. You're like, I've got this.
It's a great question, but if you're in labour, it's too late.
Oh, yeah.
And that is why you got to talk about this in the consulting room during the pregnancy. So in our Grow My Baby program, we've got a template for a birth plan. I believe in birth plans. I think it's really, really great to get on paper how I hope this goes. Yeah. But the process of making a birth plan, it's great. Not for the plan. They're all right. It's for the questions that it introduces in the mind of the patient. So if someone comes to me and says, I don't want Syntocinon under any circumstances, I'm like, okay, well, this is your body, your choice, 100%. You will not have a drug from me that you have not agreed to having. However, what do you want to do if you get to 5 centimetres and the labour stalls? And woman will often say, I didn't know that was a thing. I'll say, that's why the clever people invented Syntocinon. So let's talk now about what we might do, because we've got some choices. You could keep waiting and hope that we get there eventually, and that has risks and benefits. Or we could do a Caesar then and there because we only got to 5 and you can't get baby out through 5. Or you could have Syntocinon. And then people go, so through learning about it, they can suddenly start getting back to this idea of engaging in the complexity. They go, oh, it's not just simple enough to say, no, I don't want that because it's bad for me. Now I can see how the use of that might get me out of trouble. Then they go away and have another think about it.
Yeah.
Yeah. Now, if that person comes back and says, I don't want I've had a look and I had to think and I don't want it under any circumstances, fine. But you cannot escape the consequences of not having it if you get into that situation. We'll have to do something else, and those things will have their own pros and cons. Yeah. Even if that something else is nothing. It's got its own pros and cons.
Which must be incredibly difficult for a provider if that person goes, absolutely, I'm saying no to that particular intervention.
Yes.
And the risks and benefits in the practitioner's mind really doesn't equate. Like the risks are far greater.
Yes.
And you think, well, the option that this woman is now choosing is that she wants a labour to go for 2 days.
With the associated risks. This is a tricky one because in my view, the absolute paramount consideration is the wishes of the patient. Now, I don't think that can truly be determined, the wishes of the patient, until the patient understands the counter-argument. So I spend a fair bit of time, if I'm in a situation like this, making sure that the person understands the counter-argument before making their final decision. And when they do, that's the decision. So if someone wants to stay in labour for days and days, that is okay. It hasn't happened that many times in my career, a few. But that is okay if that's what they truly want. And some of those people aren't in the hospital in the first place.
Yeah.
They're labouring out in the community in a way that they feel is best for them. I don't like the idea of people having rejected intervention and the medical point of view without having heard it first and understood it. But ultimately, if that's what they've decided, then that is up to them. And my junior colleagues get very upset about this. And they feel powerless and frustrated and a bit depressed that all of the clever interventions that they spent so long learning about are being rejected by the patient. But ultimately, that is their decision. And sometimes that leads to people, very often, that leads to that person getting away with it. And feeling clever that they
they had a natural birth and it only took 12 hours.
It was all great. And then
they get on the internet and tell
everyone else to do what they did. But sometimes it leads to poor outcomes, and that is part of making a choice. What's the decision? What do we do? Tie people down? Absolutely not. This is not the way we do things.
Or withdraw care.
Altogether.
Yeah.
Well, that's a tricky one. Yeah.
But I mean, that's what that case with the woman who didn't want a vaginal examination, and they were saying, well, we're not going to accept you into the hospital unless you have one. Yeah. A
better scenario would have been that someone has the right to come into the hospital, but also to reject things that hospital is recommending, because if someone wants to do that, there's an argument that's often made that if you're so clever and you know the best way to do everything, why are you in the hospital in the first place? Well, that argument falls down because that person might say, no, I have a vision for my labour that I want it to run like this. But if it completely goes to crap, I want to be in the hospital where you people can help me. And that's a legitimate point of view. Yeah. Our point of view is often based that prevention's better than cure, and we'd rather prevent the postpartum hemorrhage than have to come running and fix one. But again, that's it's up to the patient. Yeah, the informed patient.
Informed and not scared into doing something. All right. So in terms of the drip, people can ask, why are you recommending that I have the drip?
Yes.
They can ask, what are the risks? What are the benefits?
Yeah. If I do this, if I do nothing, or how about we do something else? That's not can, should. Yeah.
And that all should probably happen, you're saying, before labour.
Well, that's our dream, isn't it? That's what we wanted. That's why we made the Grow My Baby program, was to try and get people up to a certain amount of pregnancy literacy, such that when some of these things happen in their labour, which they do, it wasn't the first they'd ever heard of.
Yeah.
Right?
Yeah.
And anecdotally, I think that it's great to talk to people who already understand what the hell you're talking about.
Yeah.
Yeah.
Yeah. Great. All right, everyone. Pat's mentioned our Grow My Baby program a couple of times now. So if you're interested in that, there's always a link to that in our show notes. What it is a week-by-week, really in-depth information that you get to help you in pre-pregnancy, all through your pregnancy, and for the first 6 weeks. You can join at any time. We think it's really affordable to get quality consultant level information that's not just Pat, a little bit of me in there as a mum, but there's also other experts that we've invited in to, like we've got an anaesthetist, a physiotherapist, dietitian, lactation consultant. So all of those things really help wrap the information that you're learning on the podcast into a step-by-step sequential-led information program. So we think it's really great, and thousands of other people have thought it's really great too. So the links to that are in our show notes. So good. I'm glad we covered the drip.
Me too.
It's something that does get a bit of airtime. So yes, you've got lots of knowledge now. Take this away, digest it, talk to your support people, talk to your partner, and see what decisions you're going to make about induction or augmentation.
Excellent.
All right, everyone. Until next week, keep growing those babies, and we'll be back in your ears then.
Thanks for listening, everybody.
Okay, bye for now. Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.